Hello friends, today we are going to see this video of a robotic assisted hysterectomy with bilateral salpingo-oophorectomy when the patient who was 48 years old with adenomyosis and she was previous to cesareans. So the additions which you just saw and the other additions are also there because of the previous surgery and associated adenomyosis. The left adnexa is being taken care of. Progress is helping in picking up the adnexa and as if it is your other hand or the other accessory instrument. Once you give the adnexa to the progress, then you use your bipolar in your left hand and the monopolar in the third arm, which is next to your camera port. And intermittently coagulation with bipolar and cutting with monopolar scissor is being done. Photographs intermittently, which is in your control, is adjusting the position of the adnexa, the traction, and there's also a manipulator in the uterus to take the uterus to the opposite side. The round ligaments have been done and the leaves of broad ligament are being opened. Any small spurters coming in the way are coagulated. The bladder is checked. You can see the impression of Foley's. Now we move to the adnexa of the other side. Once again, the progress is holding the adnexa up and bipolar and monopolar together one by one. We are coagulating and cutting. Now again progress holds the round ligament, stretches it. The uterine manipulator stretching the adnexa from the vaginal end. Together they give a good stretch and the dissection is done. Now we move to the bladder. So she was previous to cesareans, the bladder was adherent. I prefer filling up the bladder with patient's own urine. Means we clamp the bladder after we put the ports and we know we are approaching in 15 minutes or so, whatever time we have. So the bladder gets filled by the time you finish the adnexa and other structures. Gradually, with a lot of magnification, camera moving in and out as per the need, we are going and cutting the fibers very gently, more towards the uterus. The uterus has been pushed retroverted and kephalate towards the head of the patient and retroverted. As the fibers are being done, are being cut, the blade of the monopolar, the body of it is pushing the fibers down to give a good plane. Most of the uterus is being pushed along with the fibers gently with all the yellow fat indicating that the bladder is there. Small bleeders are taken care of on the way with suction and point coagulation wherever required. Once the bladder has been pushed, the uterines are being taken with bipolar from the left side and monopolar coming from the top from the right. Unlike laparoscopy, here in robotic, the instruments are almost all approaching from any side. So there is not much difference, no preference on which side you should use which instrument. And you also have an option of port hopping. So if required in large uteri, one can hop the ports and change the position of the camera as well as of any of the instruments can be changed. So remaining part of the uterus is being coagulated and cut and the bladder is further being pushed down. Uterus are being done on the right side. Now the bladder is finally pushed to check and decide the point of colpotomy. The assistant pushes the vaginal tube and you can see the rim very clearly. In robotics, there is no touch sensation, no haptics. Hence, magnification has to help, and 3D vision really gives you the view. Once the colpotomy is done, you can see the valsalum and the blue tube. Then you just have to follow that. At the corners, at the angles, you will find vessels. So, little bit coagulation is required once again before you cut the vaginal fornices with monopolar scissor. The uterus has been pushed to the opposite side as we are doing this. It's always better to control bleeding by more coagulation rather than finding the bleeder once it slips. And with the uterus in situ, you can push the bladder once the uterus has been taken out and there are bleeders, you come closer to ureters and there's a higher chance of injury to the ureters. Remaining vessels being done on the left side, coagulation and cut. Posterior part by acute anteversion of the uterus. Sometimes uterus is big, so in that case again progress comes to help you to keep the uterus anteriorly bent so that the posterior fornix gets more prominent. You can see the wrist motion of the robotic instrument tips. And with 30-degree up, you can have a upwards view at this stage of the surgery. The 30 up and down is also under the control of the surgeon. From the console itself, you can just click a button and take the vision up or down. Now suturing begins with barbed suture, taking uterosacral also into the first bite, and the suturing continues with deep bites completely involving the margins of the vagina. Equally spaced bites are important, about 1 centimeter deep on each side. With the loss of haptic, it is important for you to know. You have to know with your mind that you want the needle to come out at this particular point. And that is how your pressure and your movements, they all work. Remaining fibers of bladder are being pushed. The same suturing is continued throughout. Every time you see, I pull the suture. You may take 30 centimeters, 15 centimeters, anything. This one was 15 centimeters, hence it is doing little short. 30 centimeters, you can also go backwards to take the endopelvic fascia and do suturing. Once the suturing is completed, needle is removed under vision. Final check is done. Ureters are checked on both sides. Hemostasis is checked and the needle is removed. Always you should take out the needle under vision, holding it with a needle holder. Hence you should leave a little bit of thread on the needle so that a holder can pick it up and take it out. That is, ureters being checked on both sides. That's a final picture of the vault, what you are seeing. If any bleeding is noted, it is touched with short spurts of energy here and there. Giving a good wash, you know that the surgical side doesn't have any bleeding. Air saline test we do at the end. Cystoscopy is not mandatory. That's the end of the surgery. Thank you very much for watching this video.